Good afternoon. This is Bariatric Friday. My name is Kemal Erkan. I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing great. Sorry to delay our Bariatric Friday, Kemal, but we are back here and I'm very happy to be here as usual.
You know, what's important is we have a clinician, surgeon who's with us, and we know the difficulties with clinicians' lives, right? So things are happening and you take care of patients, so that is absolutely fine. So Dr. Irgau, today we are gonna go back to one of our previous discussions that we had. Lisa Presley, who passed in January 2023. And we did have a session, but that time we did not have the autopsy report. Since then, we were able to get the autopsy of her case. And we wanted to actually provide some solid, reliable information, objective information to public so that this perhaps misperception can be cleared and more people can understand what may have happened. So we got the report, several pages. This is available to, I guess, anyone who requests this. So it's not it's not a private information. So, and then we were trying to make, trying to be very careful not to make any comments without understanding exactly what happened. But whatever was known to us in terms of her history of over-medicating, unspecified drug use, these are from the report, and alcohol abuse in the past, and several other clinical complications that she had. We were making our assumptions based on those, but now we have the report. So I want to bring the first page of the report, just so that how they conclude, so that we can kind of see what was happening. And then if you can actually tell me what your take is on this case, and like after that, how it changed.
Yeah. So the autopsy report, as you mentioned, Kemal, is obviously an extensive report that includes the report of the autopsy surgeon, the pathologist who went through the examination of different body parts to try to ascertain what may have gone wrong to cause, the ultimate passing of Lisa. But also there is information, albeit limited, about what had transpired on that day in which she got ill, essentially. So that is important information to try to gather. So there is one conclusion that is irrefutable, and it's supported by the finding of the pathologist who performed the autopsy. For those who may not be familiar, Kemal, an autopsy is what we call a post-mortem examination. In other words, after the person has died, an examination is undertaken, which is different from the examination that you do on somebody who's alive, of course, because now you're relying on information based on what happened to the tissues of the person. So you're going to methodically go through different organs to try to figure out, the process that has led to the illness and then ultimately to the demise of the person. And of course, as we know, not every passing of a person, requires an autopsy, but there are specific circumstances where, for instance, someone is passing suddenly, there is suspicion that they may have passed because of harm. Then in those situations, the law is also involved and it insists on getting a post-mortem examination, which will help them ascertain whether there had been any foul play in the passing of the person. So essentially an autopsy is that type of examination. It's very thorough. It's done by experienced specialists who are pathologists, and their specialty really is examining parts of the body after the person has died to try to figure out what looks normal and what does look abnormal. So in their report, in the report of the pathologist, one very clear cause of death, Kemal, is what they call intestinal ischemia. In other words, part of the intestine, of the digestive system, particularly the longest part of the digestive system, which is the small intestine, had died before the person actually died. So that was really what precipitated the death of the person. When you have ischemia, which means lack of blood supply to the intestine, that leads to a very severe reaction and condition called septic shock that, if it's not treated, anybody will actually die from that condition. So the cause of death is intestinal ischemia. In other words, the intestine did not have blood supply. That's the number one line they have there, right? So the question is, why did that happen? And importantly, in the discussion we have in our Bariatric Friday, because this issue was raised by many people within the bariatric communities, was this caused by bariatric surgery, right? Is there a cause and effect relationship there? And that's what we want to clarify here. And I think looking at the autopsy report itself helps us to really suggest what may have been the real cause of the intestinal ischemia, and if there was any relationship at all to her history of bariatric surgery. That's what we want to get to, essentially.
From the autopsy report, on the toxicology, there are 3 medications that she was positive. Oxycodone would be one. Buprenorphine, is it? That's for that's for obesity, I believe, weight loss. Or it was
that's one of the medications that is given to people who have long-term chronic pain, and that's one of the ways to tackle it, essentially.
And it's also maybe also related to depression?
Possibly.
And then the third one is quetiapine. That's also narcotics. So there are 3 narcotics was in her blood. So we don't know whether or not they were actually given. Well, I'm sure she had a prescription, but when you have that much money and big name, you are able to get those, just like the way that her ex-husband, Michael Jackson, was able to get. They were able to get those things at their home. So this was, we are kind of looking at it not just from what really happened, but also what are the other contributing factors at the time of her death. One other thing that Dr. Ergau, if I may, before we go into too much of the clinical side of it, well, you and I, we didn't discuss this, so I want to actually point out one thing, and I just find this interesting. So the pain started in the morning, and her husband, she did tell her husband, I guess, her husband left
ex-husband.
Her ex-husband. She, well, because he was there, so I'm thinking that they were maybe
right.
So he left with the kids to drop them off to school. So I don't have kids. You do, and you did a lot of schooling. What time the school starts?
So it should be, early, essentially. You probably are leaving the house by 7:30, I guess, for most people, right? Depending on how far it is from their house to school, right?
Even if it's 8:30. So they didn't get to the hospital until 11:21. So minimum 3-hour delay there just to get to the hospital. So that's one thing that I wanted to actually mention. So that's the admission time. So
right. So to clarify that, Dr. Kemal, essentially, when the ex-husband got home from dropping the kids to school, he found her down, right? And then he called 911. 911 actually, the emergency services got to the place within 10 minutes after that call, right? So he got home, probably we have to assume around 11 o'clock, maybe a little bit before 11 o'clock, right?
Maybe
he found her down. They estimated that the downtime, meaning that the time in which she was actually down on the floor, might have been maybe 10 to 15 minutes, right? So we have the morning, right? Let's say 7 a.m., 8 a.m., whatnot. she was complaining of abdominal pain at that time, right? That is written in that report, based obviously on the witnesses that the police had talked to, right, which included people in her household. Now, so she's complaining of abdominal pain at that time. Now her ex-husband leaves, right? He goes to drop the kids. He comes back maybe 2 to 3 hours later, depending on what time he left, based on what you were saying to school. And then he finds her down, right? Now, between when he left, when she was having abdominal pain, until he came back maybe about 15, 20 minutes before he got back, which is maybe 2 to 3 hours, she was still awake, but still having the pain, right? So the question would be, she didn't call an ambulance, she didn't call the hospital, she didn't call for help at that time. So what was happening at that time? And then, of course, one of the things that you could think of is that because she did have pain medication available to her, remember one of the things that they mentioned is she did have plastic surgery not too long before this episode, and she was taking pain medication. Maybe she was taking the pain medication to try to ease the pain that she was having, right? And that was maybe one way for her to take care of it. But obviously this was a severe condition, right? And so when he returned, she was on the floor, she was unconscious, not only unconscious, but apparently there was no heartbeat, right? And he started CPR. Her ex-husband actually, the report says, started CPR at that time, right? As he was waiting for the emergency services to appear. And then obviously once the emergency services appeared, they continued with the advanced type of CPR, and they were able to restart her heartbeat, and then was taken to the hospital with a heartbeat. But then in the hospital again, her heartbeat stopped, and they resuscitated her again. They were able to do many type of maneuvers, including put a pacemaker at that time to support her heart, but also to do an X-ray. They were able to do a CAT scan, which showed that there was distension of her intestine at that time. And then, of course, after that, her heart stopped again, and they continued resuscitation, but then they were not getting anywhere. And they did do a CAT scan of the head as well, Kemal, which did demonstrate that she had something called anoxic brain injury, which means that her brain did not have oxygen for quite some time. So maybe during the downtime, her heart already had stopped and she was not getting oxygen. So potentially irreversible brain damage may have occurred already at the time in which she was in her house, Kemal. That's one of the suspicions that you could have, essentially.
So now with the small bowel obstruction,
yes,
my understanding and some of the discussions that we had, so they relate this to scar tissue issues with the bariatric surgery. But then when we had this first session, what wasn't available to us, which is available to us now, which I'm going to bring up this, she also had appendix removed.
Yes.
Right?
Yes.
So not only that, she also had her gallbladder removed. So this is the gallbladder one, and this is the appendix one. So what does this tell us? And why would they actually, because it's an abdomen surgery, like it's not just the bariatric, anything that's happening in the abdomen that can actually cause the small bowel obstruction, right?
Absolutely.
So why do they dismiss these two really important surgeries?
So again, I think one of the conclusions from the report, as I said, the main one was saying that there was intestinal ischemia, right? Describing that a very large portion of her intestine had actually died. And I will talk about how dangerous that is in a second, right? But then they say, secondary contributing factor, they say history of bariatric surgery. Well, in essence, if you take this at face value without looking at the actual reports come out, you would think, oh, maybe she had gastric bypass, which is one of the more common procedures we have, right? And then with gastric bypass, you can have something called internal hernia, which we know can happen, can happen up to 10 to 15% of people who had gastric bypass. And if they are not treated promptly, this can cause problems. So that was the assumption, right? But actually, Lisa did not have gastric bypass. If you look at the description of the anatomy that the autopsy surgeon found, he found that there was a stomach that had staple line on the left side, which means the stomach was cut in the shape of a slit. And then the intestine was connected to the lower part of the stomach, which is something you don't do with gastric bypass. And then more importantly, the length of the intestine that was bypassed, Kemal, was almost 18 to 20 feet. I mean, it was almost the whole intestine was bypassed. And that is a procedure you do with something called the duodenal switch, Kemal, but there is actually a variation of the duodenal switch where there is just one connection, which is known as a single anastomosis duodeno-ileal bypass. So she did not have gastric bypass, right? So this was not gastric bypass. This was not an internal hernia caused by gastric bypass, which many people may have assumed, right? So her surgery was, yes, bariatric surgery, but it's actually not a common type of bariatric surgery. Certainly, it wasn't just a sleeve gastrectomy, and it wasn't gastric bypass. As I said, it is most likely something called single anastomosis duodeno-ileal bypass, which is performed in the United States, but not commonly, right? In fact, there are few places that are performing this just for a number of reasons, essentially. So she did not have the classic bariatric surgery. But then the other important part, Kemal, is that one of the causes of ischemia of the intestine is bowel obstruction. And as you correctly said, any operation in the abdomen can cause scar tissue that can result in bowel obstruction, right? Mm-hmm. But where was her bowel obstruction? Well, the description given by the autopsy surgeon, Kemal, is that this obstruction was in what we call the posterior peritoneum in the right lower quadrant. And what surgery is done in that spot? Appendix surgery, right? So that scar tissue that had caused all that could be related to her appendix surgery, right? That's very important to understand. But there was definitely twisting of the blood vessels that go and supply the intestine in that area. Now, what is surprising is that the twisting of the blood vessels in that area didn't lead to ischemia of that portion of the intestine. It led to ischemia of the entire intestine, right? Mm-hmm. Now, when that happens, when the blood supply to the intestine falls apart, something very dangerous happens, Kemal. And that is the actual wall that encloses the inside of the small intestine becomes leaky because the cells start to die. And what do we have inside the small intestine, Kemal? We have billions of bacteria. But those bacteria are good for us when they remain within the intestine. But once the wall of the intestine becomes leaky and they start going to places they're not supposed to go, then that causes an overwhelming infection that results in this extremely dangerous and lethal sepsis, right? So that is what has happened, right? Now, a question that, I have, obviously, looking at this is, Kemal, is that why wouldn't a person who's developing ischemia seek help at that time? Because one of the things we know about intestinal ischemia, Kemal, is that it causes tremendous pain. I mean, the amount of pain is very, very, very high. In fact, we talk about, the pain being well disproportionate from what you see on physical examination. That's one of the hallmarks of ischemia, right? So unless she was really trying very hard to medicate herself at that time, right? With the medication she had, anybody without medication would have reached the phone and called 911 with that type of pain. And what's the importance of calling for help early when this happens? Well, ischemia takes time to develop. And when you go early to seek help, Kemal, you can get there before the bowel has died, before the leakiness starts to occur in the wall of the intestine. Therefore, you are able to get there, relieve the obstruction with a surgical procedure, and then the blood supply can be restored to the intestine, and that person obviously can be saved. But this did not happen. She was at home until the full spectrum of the ischemia evolved and got to a non-reversible stage, which led to her demise, obviously. The fact that they found that there were pain medication in her system suggests maybe she did try to do that. And of course, you mentioned the buprenorphine as well, which is a type of medication which is actually similar to Suboxone, which you are familiar with because you see it in the primary care practices that do pain service, right? The common pain management.
For the addiction management.
Right. So for people who have problems with potential addiction, that's a medication that is prescribed essentially. So probably there were these issues at play as well. And how would they have contributed to this condition, in my view, would be the fact that maybe she did try to self-medicate at that time, thinking that will pass away. Obviously, when you have pain and you're able to take medication to suppress that pain, maybe you're thinking, oh, maybe I'm constipated, maybe I have like a stomach virus, may have indigestion. That's the kind of things that would go to the mind of a layperson, right? And if you get medication and that medication is taking the edge of the pain, then you're more likely to think that way. Otherwise, somebody who doesn't have access to medication when they have this type of pain, Kemal, they're not going to wait even a single hour before they really reach for help, because the pain itself is extremely severe.
Now, so it's kind of important. So the Suboxone for the addiction, usually that's for heroin addiction, and it's only given by specialists who has certification, I believe. Not because not everyone is doing that. In Delaware, there are only a couple available options. Now, that is one issue. But the reason she was on a pain medication was the recent cosmetic surgery.
Right. So apparently there was cosmetic surgery at some point, and then there was a complication related to that cosmetic surgery that led to hospitalization. And after that hospitalization, there were obviously this the prescription opioid medication. Now, to clarify one thing, Kemal, this buprenorphine is not the same as Suboxone, but Suboxone has two substances in it, right? Whereas the buprenorphine has one, which is like a kind of narcotic, but is sometimes used to either for pain medication itself or to help people get out of addiction to opiates as well. But these medications were definitely at play. And the reason I am talking about them again is to try to explain the reason for the delay to call for help, right? If the abdominal pain was there, in the morning, it's possible also that the abdominal pain maybe was there in the night as well, and maybe nobody else was awake for her to be able to relay that. All we know is that in the morning, she was complaining of abdominal pain. But obviously, if the husband was able to leave, the ex-husband was able to leave the house to take care of the kids at that time, maybe it wasn't that severe. Maybe the reason it wasn't that severe was maybe because she was taking some pain medication to try to suppress it, essentially.
So, my point, though, on this issue, so small bowel obstruction is not a deadly situation if you have a medical attention in a timely manner.
Totally. Absolutely. Yes.
It can happen to any of us.
It's not anybody who's had previous surgery particularly would be vulnerable to this, but any surgery, yeah.
But then there is other issue of, again, drugs and alcohol, which contribute to the delay of this getting the medical attention. Now, one thing that we do in our surgery center for our bariatric patients, we don't do narcotics.
Absolutely not. Absolutely not. We've gone away from narcotics completely.
But why are we not doing that? What was the reason that we stopped doing it, because there is a cost to us by not doing it, right? Because we have to do certain things ahead of time, so then we can better prep the patients. But why are we not doing the narcotics? So maybe if we can explain that, so then we can highlight this issue of narcotic utilization, which is not common or shouldn't be common.
Yes, absolutely. So one of the first thing is obviously we are being very diligent in, avoiding to contribute to this opioid epidemic we have in this country, right? Because, liberal prescription of this medication to some extent maybe has contributed to this opioid epidemic. But also, importantly, we know that opioids actually, Kemal, delay the recovery from surgery as well, either by delaying, the activity of digestive system, by making the person less active. So a whole plethora of problems can arise if the person is taking heavy doses of narcotic medication after surgery. So one of the biggest advancements that we can make as surgeons is really take care of the pain that occurs after surgery without utilizing narcotic medications. And guess what? We have been able to do that very successfully, because taking care of pain starts before the surgery. In other words, we plan for this by doing things even before the surgery, and also doing things at the time of surgery that will minimize pain, essentially. So we don't see much narcotic use in our practice. In fact, we see extremely little narcotic use from that point of view. Not only narcotics that prescribed and to the patient, but also the anesthesia team itself uses very little narcotic medication during the surgery itself, so that there isn't that kind of dependence of the body on it, and also the effects of the narcotics on the body that is recovering.
So it's interesting that on the report how they say that these are not contributory to death. Well, if I can function, and if I need to call 911 or tell someone that I'm really not feeling good because I'm medicated, like, how is not contributory? Like, how can we say, like, whoever wrote, whoever this report is written by, how can they say that when we know that this is going to delay? Like, oh, so you have an accident while you were speeding, yes, but then you were drunk. Oh, alcohol didn't have anything to do with it because this other car just, pulled over, or they stopped all of a sudden. The reason we don't drink and drive, I guess, or doing drugs while you are driving is because it's delaying certainty, because unexpected things are going to happen, right? So then you can drink at your home, but you cannot drink while you are driving. So that's simple. So why is it, like, why do they not highlight that part, and then they're just blaming straight to the bariatric surgery, knowing that there is gallbladder surgery, knowing that there's appendix, knowing that how many cosmetic surgeries she has?
So interesting, Kemal, because clearly the number one cause of death, which is the intestinal ischemia, they were able to confirm that as the number one factor, and of course support that with their findings. Mm-hmm. Right? But beyond that, it shows you that even autopsy in the best of hands, sometimes you can have some subjectivism inserted into it, right? In terms of contributing factors, especially, right? So when you say bariatric surgery contributed, you really are probably kind of guessing to some extent, or without being certain about that, but then you are not considering other surgeries, as you say. So in general, probably a more reasonable contributing factor could be abdominal surgery. Abdominal surgery, well, yes, bariatric surgery is also abdominal surgery. But when you say bowel obstruction and bariatric surgery, people typically think about the internal hernia that people see after gastric bypass. Mm-hmm. And that terrifies people, obviously, who are considering gastric bypass. But first of all, she did not have gastric bypass. That's one thing that is also important to clarify. She had a type of bariatric surgery, which is done less commonly in this country, right? Now, whether this was a type of surgery that was done in one setting or whether it was two, we don't know, obviously, because we don't know. But the anatomy that we find described in this autopsy report is not gastric bypass by any stretch of the imagination, right? It is very similar, most likely, to what I call a single anastomosis duodenal-ileostomy, which means, or ileal bypass, which is a procedure more similar to duodenal switch than gastric bypass.
So, well, what's the biggest lesson learned from this case?
So the biggest lesson, again, we can learn from this situation, Kemal, is that it's very important. It's very important that when people have abdominal pain, right, they really refrain from self-medicating themselves, and they should be, calling for help. Now, I'm not saying don't take Tums, don't take Pepto-Bismol. These are not pain medication, right? You're thinking maybe this is indigestion, so I'll be able to take care of that. That is fine. But taking pain medication to take away of a pain whose origin you have no idea as a layperson, it's not a good idea. I think it's very important to go to the nearest emergency, particularly if you've had previous history of abdominal surgery, you should do that. Now, when it comes to bariatric surgery to our patients, one of the things we instruct them is that if you have, severe abdominal pain, call us or go to the emergency room, because there are potential issues that can occur with any abdominal surgery that can, cause abdominal pain, bowel obstruction, and so forth. That is just part of the nature of the intervention itself. So that is an important lesson in my view. But the other important lesson, of course, is that when you are, particularly for the media, right? They are the ones who divulge the information, right? When they are saying, somebody well-known in society has passed away because of this procedure, then clearly that creates a lot of anxiety on people who may be preparing to have that procedure or have had that procedure, right, without knowing the details. And I actually appreciate you, Kemal, bringing this issue up and going to the extent of getting the actual report and then examining it to try to really shed light to this, because I haven't seen any other outlet really do this in this sense. So it's important for people to
the way that they covered is mainly based on bariatric surgery caused that. So,
right.
Which what we were trying to do since the beginning, highlighting other issues, and also like why it's important to go through reliable sources. So that's one of the reasons we do this. Now, one of, like, as you were talking about this, one thing that I just thought about, like, as much as money she has, she didn't have anyone at home and relying on the ex-husband to be back. Like, this person's worth like 150, 200 million, did they not have anyone at home?
Not sure, Kemal, that does sound a bit odd. Yeah, you're absolutely right.
That's not related to the issue, but I just thought about it. Like, why would she not have anyone? You would think that she had at least 3-4 people in the house, but looking for time to help is important. So that means you have to be alert. That means you shouldn't be doing the way that they were saying is over-medicating or unspecified drug use. These are things that are not going to be known by the clinicians unless they do some testing, and they cannot do that all the time if you are getting this from different sources. So this is important, so that especially, I always think about why we treat sleep apnea if it's really out of control, is because anything can contribute to complications after surgery. And if patient is not, one of the reasons that we try to avoid narcotics is because patient needs to be alert, so then they know what's happening during their sleep. Even with the CPAP, you have to have your good alert mindset when there's an emergency, right?
Absolutely. I mean, having said that, of course, it does not mean that there aren't any situations where narcotic pain medications are important. Of course there are, right? But obviously they are limited. But clearly, if you have been given narcotic pain medication for one problem, then your utilization should be restricted to that problem, right? That is very important. Or if there is narcotic pain medication that a member of a household is using, only that member should be using it. It should not be accessible to anybody else for any reason, essentially, because these are highly regulated medications that, improper utilization can lead to a lot of problems. That's why it's important to have this type of restrictions in place. And that's why we obviously think that the utilization of narcotic medications in the past was not a good idea. So as surgeons now, we feel very responsible when we write pain medication in restricting ourselves to non-narcotics whenever it's possible. And for the vast majority of the elective procedures that certainly we at CHRIAS perform, we are able to accomplish that with complete control of the pain at the same time, because we can use alternatives that are much less dangerous to the person, but they're effective at the same time. Because at the end of the day, obviously, we want to control pain. Control of the pain is critically important for the recovery of a person from surgery, and we are able to accomplish that well without utilizing narcotics.
Well, we tried to cover Lisa Marie Presley's autopsy report today. This was our second session related to this topic. I'm hoping that people who are watching this or who will be watching this later on, they find these helpful. I do want to thank Dr. Irgau joining us and explaining this the way that you did. It's easy to follow, number one, because sometimes, with the doctors, they talk like a different language, but when I'm listening to you, I can actually follow what is happening. So thank you for that. And I know there are a lot of people looking for help out there. Again, only 1% of the population that's eligible, qualify for bariatric surgery, is getting bariatric surgery. And surprisingly, with the weight loss medication we discussed, only 2% of the people are utilizing the weight loss medication. So this is a disease that's not being treated and not being taken seriously. And our goal is to increase the awareness for issues related to morbid obesity. Well, Dr. Irgau, thank you so much for joining us.
Thank you, Kemal. Thank you. Have a nice weekend.
Bye-bye.